Thank you very much for inviting me to talk to you about the cardiovascular effects in the aftermath of COVID-19 infection. By way of introduction, I'm a cardiologist, clinical pharmacologist, and physician. I trained in the UK at the Imperial College London and later at the University Hospital Frankfurt. In addition to my academic duties that focus primarily on the development of imaging methods for myocardial inflammation, I also run a busy cardiac long COVID clinic in Frankfurt and in London with over 600 patients scanned and with regular follow-up. Here are my disclosures. Although primarily considered to be causing an acute febrile respiratory illness, including pneumonia, the toll of COVID infection on cardiovascular system became soon apparent. Here are a few early reports from China, primarily focusing on hospitalized patients, showing a considerable rise of serum cardiac biomarkers such as troponin, indicating direct cardiac injury, and BMP, indicating sufficiently high left ventricular wall stress to indicate high likelihood of clinical heart failure. Notably, the rise of these biomarkers correlated with CPR, indicating the parallels between the febrile state and the strain put on the heart muscle. In those patients that had higher levels of troponin release, the clinical course was clearly worse, including the higher rates of hospitalization and death, as shown in the figure on the left-hand side. The figure on the right-hand side informs that patients with pre-existing conditions as well as high troponin release are particularly affected. The susceptibility of the heart muscle to the virus was better understood after the discovery that angiotensin converting enzyme receptor 2, the cellular entry mechanism, was abundantly expressed not just in the lungs but also in the heart. Here is a study from our sister research group from Frankfurt explaining the greater susceptibility of patients with pre-existing conditions by showing endothelial cells, cardiomyocytes, and fibroblasts to be more prominently expressing these receptors in the presence of cardiac disease, something that was also reproduced in an earlier study, as well as that this observed upregulation of ACE2 receptors was less prominent or near normalized when patients were treated with ACE inhibitors, thus conferring cardioprotection. This important finding was retrospectively clarified in the outcome data from the Madrid cohort of the first wave, substantiating the worse prognosis in patients with known heart failure, as well as the better survival in those that continue to receive heart failure treatment, in particular ACE, ARBs, aldosterone antagonists, as well as the beta blockers. Clarifying the substantial confusion of these early days of the pandemics, that these medications are protective and not the opposite. This study also highlighted that in addition to the older age and pre-existing cardiovascular conditions, factors related to the strain of the febrile systemic illness, such as tachyarrhythmias, play a significant role in pushing patients over the edge and into the heart failure. The dominant role of atrial fibrillation among the arrhythmias in tipping patients over the edge was highlighted in this retrospective review of 700 patients, showing that AF in combination of hypertension, diabetes, and obesity has the highest likelihood for the patients to end up in the ITU. In this slide, I summarize some of the important mechanisms that play a role in cardiac complications during the acute COVID illness. Reflecting the burden of systemic febrile illness in response to the viral infection, hypoxemia, tachycardia, cytokine release, and hypercoagulability lead to an increased myocardial oxygen consumption, vasculitis, and thrombi formation, together pushing particularly the elderly and those with known cardiac conditions over the edge. Several studies now capture these mechanisms, which clearly have lasting effects for the patients most affected during the acute illness, as seen also in the Madrid study. And this is important to understand in order to appreciate the manifestations of the long COVID symptoms in this patient group. The role of direct cardiotoxicity and viral myocarditis during the acute illness was particularly debated in Germany. This study of cardiomyocytes in vitro revealed that that COVID-19 is able to infect these cells directly, and it is blocked by remdesivir. However, the autopsy studies from patients dying during the acute illness speak a different story. In this report from Hamburg group, the most prevalent cause of death was pneumonia. In the autopsied hearts, the viral genome was detectable in about 40% of all patients. However, the evidence of active replication, synonymous with viral cytotoxicity, was present in only 12. Interestingly, localization of viral genome was not within the cardiomyocytes, but in interstitial cells and macrophages invading the myocardial tissue from elsewhere. Further autopsy studies informed about other important mechanisms responsible for heart injury, especially along the lines of thrombus formation, including small vessel thrombi, endomyocardial thrombosis, either leading to coronary macrothrombosis causing infarction-like injury, or thrombotic showers distally, explaining the tremendous troponin release observed in hospitalized patients. This was nicely captured in this early case report showing platelet consumption paralleled with troponin rise. As you can see, BNP also shot up as well, with heart decompensating, revealing huge, nearly circumferential pericardial effusion in these cardiac MRI images. Here is a recent study from Imperial and the UCL that looked at the outcomes of hospitalized patients that experienced troponin leak using cardiac magnetic resonance. Patients were scanned a short while after they'd been discharged from the hospital. As expected, they were older, prevalently male, and had a number of risk factors and pre-existing cardiac conditions. These patients had on average structurally normal hearts with normal cardiac volumes and nearly supernormal LV function, perhaps explained by the post-processing approach, which includes papillary vessels as part of the LV mass and not the volumes as it's been more conventional. We can tell that these patients have been through a lot by the high count of myocardial scarring, as you can see that nearly 50% had evidence of myocardial late gadolinium enhancement. Interestingly, only a few patients had the mapping indices within the abnormal range, meaning not a lot of diffuse fibrosis or active inflammation. In fact, recovered patients had on average lower native T2 values compared to controls, supernormal finding that is perhaps difficult to explain. My personal hypothesis is that we are seeing the effects of intense treatment, including the anti-inflammatory with dexamethasone, conferring myocardial injury protection, in effect validating the hypothesis of recovery trial. I came to this point based on the example of our study in patients with lupus myocarditis, where we saw a drop in native T1 and T2 with intensified immunosuppressive treatment. Systemic inflammation is clearly a well-documented process in acute COVID illness, and here is an illustrative sketch of the many mechanisms affecting the vasculature in response to cytokine release, in particular the vascular leakage as well as cell necrosis, both processes leading to perivascular and tissue edema. We now know that cytokine levels correlate with severity and independently predict survival in acute COVID illness. Here are two landmark studies of longitudinal cytokine levels, as well as that there is a subpopulation of patients where the inflammation, that is cytokine release, appears to be ongoing, with likely diverse underlying mechanisms along the lines of autoimmunity and autoreactivity. These effects have been observed in this small but very early study from a Chinese group in young patients, average 38 hospitalized with COVID-19 pneumonia, receiving supportive treatment. These authors conducted an extensive imaging protocol with intention to satisfy the Lake-Lewis criteria. They showed that 58% of patients had late gadolinium enhancement and some other form of inflammatory signal in the area of late GAD, making it to date the study with the highest prevalence of myocarditis using this criteria. Once again, LV function between those with cardiac tissue changes compared to those without them was similar, meaning that an echo-based LV ejection fraction would unlikely spot the difference. Here's the imaging protocol of our study, which is trimmed to the essential with T1, T2 mapping, followed by the administration of Gadovist in a low dose, cine imaging for LV and RV function, and late gadolinium enhancement, ensuring that the exams are short with maximized information. Unlike other imaging groups that rely on Lake-Lewis criteria, our interpretation of findings in terms of inflammation is based on absolute measurements of native T1 and T2 and their respective sequence-specific normal ranges. This protocol is highly standardized and implemented at several centers, allowing us to compare the tissue measurements in serial fashion and between the centers. We pointedly included patients with no previously cardiovascular disease. These patients were identified by way of flyers at post-COVID clinic practices, long COVID websites, social media ads, and they have registered for our study via our website. In this publication of first 100 patients published in July of last year, we appear to have captured some of the early phenotypical signatures of long COVID presentations. Alarmingly and prevalently, in sporty and young patients, about 60% of them have been infected on skiing vacation as the primary source of infection. Only a third necessitated hospitalization and were mostly treated with supportive measures. Although it transpired very quickly that most of them had ongoing symptoms, in those early days we all thought this was probably a sequel of lung involvement. How wrong we were. Compared to controls here in these images, in these figures presented in blue, and risk factor match controls here in gray, patients recently recovered from COVID-19 infection had significantly reduced LV and RV ejection fraction, however, still close to near normal range. Furthermore, a considerable proportion of patients had significant amount of myocardial fibrosis and inflammation, and 20% of them also had non-ischemic scar. Let me remind you that this is previously fit and well population. 3 patients had severe abnormalities enough that they had endomyocardial biopsy, confirming the presence of active lymphocytic infiltration, however, with no evidence of viral genome, resonating the findings of earlier autopsy studies. A further striking observation was that when set against the time from the original diagnosis, there was no trend of abating, with persistently raised values even a few months from the diagnosis. Interestingly, also in super healthy, such as the athletes, some of inflammatory changes can be found as early as 15 days after the infection, as shown in these studies in American athletes. They primarily revealed uptake of contrast agent in pericardial space, as shown here with the white arrows, as well as non-ischemic scar shown with the yellow arrows, as well as pericardial effusion here pointed with the asterisks. Another brief communication from the States in 26 competitive athletes at a slightly later time point showed slightly higher prevalence of myocarditis. As you can see, 42 had late gadolinium enhancement. However, only 15 of those had also had other markers of inflammation to satisfy Lake-Lewis criteria. We need to keep in mind that the primary purpose of Lake-Lewis criteria is to gauge the pretest likelihood to engage with endomyocardial biopsy for definitive diagnosis of myocarditis and not to guide treatment. Here is one example from our cohort of a 29-year-old female, a marathon runner, an amateur, but of a serious kind, on average engaged in over 70 hours of intensive exercise per week. After a very mild COVID illness, she was resting a bit, but 6 weeks later, she felt well enough to do a marathon. In the following days, she started to experience severe, sharp chest pains and runs of tachycardia at rest recorded by her watch. She saw her GP that found an elevated troponin on the point of care test, sent her to the nearest A&E. While troponin was significantly elevated, all other bloods, like an ECG, echo, and even cardiac MRI were found to be normal. She was told to rest for another couple of weeks, which she did, but going back to normal proved to be impossible. Severe chest pain returned after every running, and also other, what we now commonly refer to as the long COVID symptoms, such as tiredness, siesta syndrome, needing to take a nap in the middle of the day, shortness of breath, rashes, hair loss. The patient presented to us about 10 weeks after infection, and we found that indeed the volumes were slightly enlarged, consistent with athlete's heart in a female, and her function was excellent. However, what we start seeing here is a very small pericardial effusion at the blue arrowheads, which becomes now even easier to spot on these high resolution late gadolinium enhancement images, where we see pericardial effusion, pointed to you by the blue arrowheads as a black line, surrounded by a white line here on the side of the myocardium, which is pericardial enhancement, and by this pericarditis. There are also white lines within the myocardium. This is non-ischemic myocardial scar. Based on these findings, as well as clearly symptoms, we diagnosed myopericarditis and recommended that the patient sticks to low-level activities for 3 months, perhaps even 6, allowing the heart and the body to recover, as well as low-dose colchicine for symptomatic pericarditis. We follow her up also with the imaging inflammatory markers, which show the decline in native T1 from very, very high values at the first admission to much better at week 10, and then normalized 6 months down the line. Here are some other representative cases with symptomatic myopericarditis, as you can appreciate, with variable degrees of pericardial effusion. Here, perhaps just a sliver, a little bit more in the case 2, and then perhaps also such that can be detected with an echo. And this is irrespective from the time since the original diagnosis. So yes, please do believe your patients as they present to you with what I will now call the typical symptoms of cardiac long COVID, which can range from mild symptoms such as struggling to regain fitness to proper exercise intolerance that would provoke dyspnea, palpitation, shots of tachycardia, and which can be present also at rest. Sharp but also burning chest pains are mainly related to pericarditis. However, when in doubt, stress MRI can clarify the symptom too. In what way can cardiac MRI help? It can help to better understand the symptoms and reduce the insecurity of patients about what exactly is going on, and guide patients toward risk modification or lifestyle adjustment, as we've seen in our case of an athlete. It may also help to estimate the risk of potential long-term complications such as development of inflammatory cardiomyopathy or heart failure in patients with evidence of reduced LV ejection fraction. Anti-remodeling therapy can be considered. In those with raging pericarditis, colchicine may relieve symptoms, whereas low-dose beta blockers may offer relief to those with palpitations. Does it need to be performed in all patients? The truth is that this novel generation of patients with long COVID, with little in the way of pre-existing condition, the classical approach to cardiovascular stratification is simply unhelpful. Based on our experience so far, we think that the following is a prudent, while not exaggerated approach how to go about this. On one extreme side of the spectrum, we do not recommend scanning patients that are asymptomatic routinely. However, advice should be given to them to build up fitness very slowly and gradually over the next 3 to 6 months. On the other extreme, we do recommend that individuals that are routinely exposed to extreme physical pressures would benefit from undergoing cardiac MRI, even in the absence of symptoms. This should be done at about 6 weeks after diagnosis, when the manifestations are most apparent. Patients with symptoms that suggest cardiac involvement, such as palpitations, tachycardia, shortness of breath during the daily activities, they should undergo cardiac scan. What do we do while scanning? My answer to this is we should do what we can do well, meaning the techniques that are robust and reproducible in pretty much everyone's hands. I refer to CNET sequences, for assessment of volume and function, as well as late gadolinium enhancement for assessment of scar, which also give the answers to the treatments that are currently possible. Anti-remodeling therapy, colchicine for those with pericarditis. However, I'm quite reserved when it comes to recommending any other additional imaging because it's simply not very informative, especially with regards to the tissue mapping. These techniques are not yet sufficiently standardized for widespread use. In summary, a significant number of patients post-COVID have relevant cardiac abnormalities. The true prevalence of cardiac damage after COVID infection is unknown. The main abnormalities include pericardial involvement, myocardial inflammation, and non-ischemic scar. Most patients cannot be identified by echo because the function at this early stage will be preserved. Myocardial biopsy is not useful as inflammation, if present, is likely to be autoimmune. The long-term consequences remain unknown. However, similar observation in other cohorts, such as other viral myocarditis, dilated cardiomyopathies, point towards strong prognostic influence of mapping measures as well as late GAD. With this, I would like to thank you for your attention, as well as my Frankfurt and London COVID teams, and most profoundly to the long COVID patients who have allowed me and the world to learn in the real time about the origins of inflammatory cardiomyopathies. And I continue to work hard to be able to repay them soon. Thank you.